Good afternoon, everybody. I am just going to start with my opening statement, so if everybody could take their seats. I am calling this meeting to order. Welcome to the meeting number 32 of the House of Commons Standing Committee on the Status of Women. Pursuant to Standing Order 108.2 and the motion adopted on Tuesday the 1st, the committee will resume its study on the mental health of young women and girls. Today's meeting is taking place in a hybrid format, pursuant to the House Order of June 23, 2022. Members are attending in person and in the room and remotely using the Zoom application. I would like to make a few comments for the benefit of our witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. Interpretation for those on Zoom. You have the choice at the bottom of your screen of either floor, English, or French, and for those in the room, which are not, your earpiece and your desired channel. A reminder that all comments should be addressed through the chair. For members in the room, if you wish to speak, please raise your hand. For members on Zoom, please use your raise hand function. I'm just going to remind people, we do have all of our witnesses today on Zoom, so today there should be all showing up shortly. So all of our witnesses will be on Zoom today. So I'm just going to ask that when I start to interrupt you, if you could just kind of wind it down within 15 seconds, okay? So this is just a bit of a trigger warning. As we all know, this study is very difficult. We will be discussing experiences related to mental health that will be triggering to viewers, members, or staff with similar experiences. If you feel distressed or if you need help, please advise the clerk. I would now like to welcome our witnesses for today's meeting. On the panel, as I said, everyone will be on screen. As an individual, we have Dr. April Elliott, who is an adolescent pediatrician, and she is here, as well as Dr. Ryan Van Looshout, who is an associate professor at McMaster University. He too is here as an individual. From the Kids Help Phone, Elisa Simon, the executive vice president and chief youth officer, Mental Health Strategy, and from the Kilnick Community Health, Carla Andrich, who is a counselor. Each of you will be provided 5 minutes for your organization to present. So I'm going to pass the floor over now to Dr. April Elliott for 5 minutes.
Hello, and thank you for inviting me to participate today. For those of you that haven't met me, my name is April Elliott, and I'm a devoted mother of 2 youth. And my profession of 21 years has been as an adolescent pediatrician, founder and head of adolescent medicine at the Alberta Children's Hospital in Calgary, Alberta. I'm also a certified executive coach trained at the University of Berkeley, and I work with physicians to support their burnout and proactively support their career development. I also coach parents to be more successful in their parenting interactions with youth. As a frontline clinician, I have witnessed a dramatic increase in morbidity and mental health decline in youth from 2001 to present. The availability of developmentally appropriate resources has not kept up to the rise. As we all know, the 2020 UNICEF report card shows that Canada is shamefully lower than other rich countries in providing healthy childhoods. Comparator countries concerning physical health dropped from 30th to 38th, and for mental health, 31st of 38. There are myriad topics related to youth health. This brief statement will discuss concerns related to the mental health of young women and girls, more specifically eating disorders, as this is my area of expertise and has drastically impacted over the last 2.5 years. In March of 2020, I published a paper with Professor Deborah Christie, A Year in Supporting Youth Within a Pandemic, A Shared Reflection, in the Journal of Clinical and Child Psychology and Psychiatry. We summarize the impact of COVID mitigation, school closures, and mental health impact on young people in UK and Canada. The data began to emerge that the pandemic was causing a range of harms to children, including feeling isolated and lonely, suffering from sleep problems, anxiety, depression, and reduced physical activity. Charities report increased demand for counseling, with many young people talking about how lonely they felt, and kids' helplines increased 4-fold from 2019 to 2020. Also a risk in harm for those living with emotional, physical, and sexual abuse. Many colleagues worldwide describe an explosion in eating disorders. With regards to eating disorders, the prevalence of anorexia nervosa in adolescent female is 0.3 to 0.7%, with incidence estimated at 8 per 100,000. To put this in perspective, this compares to a minimum incidence of 1.54 per 100,000 per year of type 2 diabetes in Canadian youth. Anorexia nervosa is a complex biopsychosocial disorder that interacts with pediatrics and mental health. It is an illness that can be debilitating for patients and their families, and the majority are young girls and women. Eating disorders are common and are life-threatening. Anorexia nervosa has the highest mortality of any psychiatric disorder. Mortality as high as 5 to 7%, and some report as high as 18%. With these significant medical and psychiatric consequences, an individual is 10 times more likely to die than their healthy peers. Globally, we have seen unprecedented numbers of hospitalizations related to new and severe cases, and patients are severely malnourished with increased medical complications. The COVID pandemic is a common precipitating factor noted by patients and families. They note school closures, loss of sports, not being with peers, and a recently published Canadian Pediatric Surveillance Program supports this. My recommendations. Number one, it is very costly to treat in a hospital setting. So early recognition and treatment by primary care physicians is essential. This education needs to be mandatory in medical schools. 2, increase resources for timely referral and access to trained and qualified healthcare providers in delivering evidence-based outpatient treatment modalities for eating disorders. Suppose a young person needs hospitalization for moderate to severe eating disorders. In that case, they need specialized units or staff on generalized units with integrated training carrying out these guidelines. These are few and far between, and many Canadian cities do not have them. The Alberta Children's Hospital has a catchment area of 2.5 million and has no specialized eating disorder inpatient unit. With regards to general mental health for youth, I would recommend providing more support for young people. It was already significantly stretched. We must prioritize teachers, school mental health, and increase resources. We need to focus on this COVID generation. Parity of esteem for mental health alongside physical health care is an absolute priority. Healthcare has a long history of not integrating mental and physical health. There must be significant investment in ensuring timely mental health access for appropriate mental health care where the young person lives in cities or rural settings. And finally, to bolstering the investment in mental health programs for children and youth, we mustn't forget we need to ensure there is support in place to strengthen and champion to increase human and financial resources for healthcare practitioners in these areas who are also on the brink of immeasurable burnout. Thank you.
Thank you very much. We're now going to move over to Dr. Ryan van Lieshout. Ryan, you have 5 minutes.
Thank you, Mrs. Chair. Good afternoon. I'm Dr. Ryan van Lieshout, Canada Research Chair in Perinatal Mental Health and Albert Einstein Irving Zucker Chair in Neuroscience at McMaster University. I'm a member of the Royal Society of Canada and a perinatal psychiatrist whose research focuses on developing scalable psychotherapeutic interventions for those with perinatal depression and anxiety and optimizing their impact on offspring brain development. The primary goal of my work is to disrupt the intergenerational transmission of psychopathology from parents to their children in Canada and around the world. My clinical expertise led me to be invited to lead the development of Canada's national practice guidelines for the treatment of perinatal depression and Public Health Ontario's perinatal mental health toolkit for public health units. Throughout my career, I've seen the devastating effects that mental health problems occurring during pregnancy and the postpartum period can have on children and families, and have committed my career to preventing these. Perinatal mental health problems affect up to 1 in 5 mothers and birthing parents, rates that increased to 1 in 3 during the COVID-19 pandemic. Every case of postpartum depression alone is associated with costs of up to $125,000 over the lifespan, or $2.5 billion for each single year of births in Canada. The offspring of mothers with postpartum depression are up to 5 times more likely to develop a clinically significant behavioral problem and up to 4 times more likely to develop depression in their lifetimes. Even though effective treatments can help both mothers and their children, as few as 1 in 10 pregnant and postpartum persons are able to access evidence-based care in Canada. There are many barriers to the receipt of timely perinatal mental health care in this country. In addition to time, childcare, travel, and a lack of providers, most individuals prefer talking therapies or psychotherapy over medications, particularly during pregnancy and lactation. Even though Canada is a world leader in the development of scalable psychotherapeutic interventions for perinatal mental health problems, there is still a lack of providers, national quality standards, step care models, and coordination. However, there are many reasons for hope. Step care pathways, those that match individuals to the right treatment at the right time, could substantially increase the number of women receiving effective treatment as can the application of scalable Canadian-made interventions and the task sharing of psychotherapy delivery with non-physician healthcare professionals like social workers, psychologists, and occupational therapists, and individuals who've recovered from postpartum depression and anxiety, people who are often referred to as recovered peers. Our research group alone has developed and tested several effective scalable interventions that can be delivered by healthcare professionals or recovered peers, and that can serve both as initial and later more intensive steps in step care models. For example, our one-day cognitive behavioral therapy-based workshop for postpartum depression can effectively treat up to 30 individuals at a time and be delivered online or in person by healthcare professionals or recovered peers. Our longer 9-week group cognitive behavioral therapy intervention has also proven effective for those with higher symptom severity, and its delivery has already been successfully task shifted to recovered peers and public health nurses with limited to no previous psychiatric training. These scalable group interventions have proven effective delivered in person and online, and a half dozen public health units in Ontario, including those in Niagara and Prince Edward County in Ontario, are now being trained to deliver them to mothers living in the community. We and others have also shown that treating mothers not only benefits them, but their entire family. Up to 70% of the costs associated with perinatal mental disorders are due to their downstream effects on daughters and sons. Recent research by our group has shown that treating mothers with postpartum depression leads to clinically meaningful improvements in mother-infant interactions, infant brain development, and emotion regulatory capacity, and even the mental health of older children in the home. This is in keeping with research from around the world that suggests that for every dollar invested in early childhood interventions, society reaps a $7 return. Perinatal mental health problems in Canada can be prevented, detected, and treated. And we already have the know-how to support mothers and disrupt the intergenerational transmission of mental disorders in families. The federal government can help by working together with experts to create national quality standards and to develop Canadian-specific stepped care pathways that can support the training of professionals and lay people in the delivery of treatments. Such developments will enable our Canadian-made discoveries to be scaled to improve the lives of women, girls, and all Canadians. I look forward to working together with you to help make Canada the best country in the world to be a woman or girl. Thank you.
Thank you very much, Doctor. We're now going to move over to the Kids Helpline, and to Alyssa Smith. You have the floor for 5 minutes.
Thank you so much to Madam Chair and members and staff of the Standing Committee on the Status of Women. I am thrilled to be here today. My name is Elisa Simon, and I am with Kids Help Phone. So for over 33 years, Kids Help Phone has been on the front lines, hearing from young people from coast to coast to coast, every single province. We start hearing from young people at about the age of 5, and we have no upper age limit. And so young people come as long as they want, and use our stepped care model in order to find the kinds of services and supports they need. We have always been a critical part of the mental health infrastructure and systems for young people. But since COVID, that need has exponentially grown. In fact, since the beginning of COVID, Kids Help Phone has supported young people over 12 million times, which is a significant increase from 2019, when we supported young people about 1.9 million times. 74% of the young people who reach out to us at Kids Help Phone identify as female. And they reach out about every challenge that a young person experiences, from bullying, depression, anxiety, relationship issues, and suicide. Although we hear from young girls and women across the age spectrum, 46% of our users are in the age range of 14 to 17, which is a particularly important time in the development of young girls. And what we see is that the challenges they're facing changes over time, which makes sense for anyone who is around young girls and young women. Not surprisingly, younger girls come to us in very high numbers about bullying and relationship challenges. In fact, girls 5 to 13 are 120% more likely to talk about bullying and cyberbullying. And that is quite detrimental to the well-being of young girls. We know that it can lead to anxiety, poor body image, lowered school performance. It is also worth noting that younger girls are more likely to reach out to us about eating disorder and body image challenges. In fact, girls 5 to 13 are 34% more likely to reach out about those challenges. As girls age, as I said, their challenges change. And so we see, for example, 18 to 24-year-olds more likely to come to talk about anxiety and stress. And interestingly, over the course of COVID, young women 25 and older have been coming 60% more often to talk about grief, which I think makes sense given so many of the losses that we have all gone through over the course of the pandemic. But perhaps most sobering is our data on suicide. Over the last 5 years, we have seen a significant increase in the young people reaching out to talk about suicidality. In fact, about 23% of all girls and young women who connect with Kids Help Phone are reaching out about suicide. 46% of girls 14 to 17 who connect with us are talking about suicide. And perhaps even more surprising is 21% of girls 5 to 13 talk about suicide, something that I think is quite shocking to many people, as we don't anticipate younger girls to even be thinking about issues around suicide. The good news that I want to make sure I leave people with is that we are able to help the vast majority of young people who reach out to us. We are able to safety plan with, and only about 2% of our contacts of people talking about suicide require an emergency referral. I also feel it's really important to focus on equity-deserving populations, Indigenous, Black, newcomers, 2S LGBTQ+. We know that their experience in Canada and their experiences around social determinants of health are not the same. And we know from our data that they are all struggling with one thing in common, which is isolation and feeling disconnected from others like them. Social isolation can lead to a lot of negative outcomes, and it seems particularly prevalent for equity-deserving populations. It's one of the reasons last year we started our peer support service, specifically so that young people can connect to others. Our data also demonstrates, for example, the incredible impact of racism and discrimination on young people from equity-deserving populations. After the murder of George Floyd in 2020, we found that young people that reached out discussing racism were more distressed than any other service user, except for those who feared harm in their own home. And they were more likely than any other service user to discuss suicide. So, in closing, I have 3 recommendations. We need to focus on equity-deserving populations and the specific needs that they have. We need more in-school supports at every age along the spectrum to not only talk about mental health, but equally important, to talk about help seeking, what it means to not feel good and why reaching out is important. Kids Help Phone has been doing this in middle schools for many years and just launched a high school program. And next year we'll be launching an elementary school program.
About 15 more seconds. 15 more seconds.
My last thing is that we have to continue to ensure that we are making investments in evidence-informed, non-duplicative services so that we are ensuring that young girls and women can access, regardless of where they live in Canada, high-quality services. So I will end my comments here. Thank you so much.
Thank you so much. And I'm sure we'll get back to more comments from you as we're going through today. And finally, from the Kilnick Community Health, we have Carla Andrich. Carla, I'll pass the floor to you for 5 minutes.
Thank you. Good afternoon, honorable members and fellow witnesses. Thank you for the opportunity to speak today. My name is Carla Andrich. My pronouns are she, her, and I'm joining you today from Territory 1, Treaty 1 territory, which is the traditional territory of the Anishinaabe, Nihiwik, Ojibwe, Dakota, and Dene people, and the heart of the Métis Nation. My personal relationship to those treaties is that of a descendant of settlers. My great and great-great-grandparents built their generational wealth from land that was never ceded. I carry the benefit of that wealth and so also the responsibility to work towards justice and decolonization. I'm a counselor at Clinic Community Health, an agency in Winnipeg, Manitoba. We've been in operation for about 50 years. We promote health and quality of life for people of every age, background, ethnicity, ability, gender identity, and socioeconomic circumstance. I'll be speaking today through the lens of my work providing one-on-one trauma counseling with survivors of sexualized violence, the vast majority of whom are women, girls, and gender minorities, with the acknowledgement that Indigenous and 2S LGBTQIA+ folks are disproportionately targeted by those who perpetuate sexualized harm. I hope to bring your attention to 3 main points today: the harm that systemic sexualized violence perpetuates, the need for trauma-informed care within systems, and the need for greater funding. Sexualized violence is a web of daily microaggressions, systemic inequalities, and acts of overt interpersonal violence. This includes sexual assault, sexual harassment, gender discrimination, and also the backlash that women, girls, and gender minorities face when they speak out. It's also an integral part of colonial harm. Indigenous women, girls, and Two-Spirit folks are disproportionately represented among the people that we see at the hospital through our advocacy work. And I've personally sat with so many Indigenous folks at the Health Science Center here in Winnipeg, from mature women, matriarchs of their families, to girls just 12 and 13 years old. And so many of them tell me that this is just a reality in their families, that their mothers, their grandmothers, their aunts, cousins, and siblings have all experienced some form of sexualized harm. Contributing to this is the systemic lack of trauma-informed care in the justice system, the medical system, other supports such as EIA, colleges of physicians, and other peripheral systems that survivors may engage with. My first counseling job was at the University of Manitoba, and it broke my heart seeing the profound impact that experiencing this harm had on my clients. Finally, and crucially, access to counseling is underfunded. Many survivors can't afford private therapy to help them recover from their traumatic experiences, and they spend months to years waiting for care at agencies like Clinic. This translates to months and years of greatly diminished quality of life, lost opportunities, lost jobs, education, relationships, and contributions to their communities. My suggestions for action today are that it is imperative that we value the futures, lives, and happiness of women, girls, and gender minorities as equal to those of men and boys. We need to more deeply commit to implementing the 94 calls to action put forth by the Truth and Reconciliation Commission, especially calls 21 through 24 and call 41. I think that trauma-informed training should become mandatory for any person or agency that provides care, reviews complaints, or enforces laws or policies around sexualized harm. And finally, that we need to greatly increase funding for survivors to access free counseling, legal support, system navigation support, and advocacy. My team at Clinic consists of just 2 full-time and 2 part-time counselors. We have a coordinator, we have a few part-time advocates, and we have volunteers, of which we ask too much because the need is so great. Essentially, we need more money. Every agency that provides this kind of care needs more money. We are stretched thin and constantly trying to balance the needs of our crisis program, which intervenes for people in the immediate aftermath of a sexual assault, and our counseling program, which provides ongoing therapy and public education. Constantly stealing from Peter to pay Paul, ultimately it's survivors who suffer. Money is how we as a society indicate how important a particular issue is to us, and Canada needs to invest in our women, our girls, and our gender minorities. At Clinic, we deeply appreciate the money that has come to Manitoba recently to help bolster our crisis services. It would be very helpful to also get money to support the other half of our advocacy and counseling work, which is for ongoing support for people, as these kinds of experiences take time and effort and support to recover from. Thank you very much for your time today.
Thank you very much for those words, Carla. What we'll be doing is we'll be doing our first round of questionings. Each member, or each going around to each party, will be provided 6 minutes. We'll be starting this off today with Michelle Frary for 6 minutes. Michelle, you have the floor.
Thanks, Madam Chair. Thank you to our witnesses. Great information that I'm sure will help in our journey here to get better resources, but better understanding and knowledge of contributing factors to youth mental health. Dr. Elliott, if I can call you that, may I call you that, Dr. Elliott? Yes. Great testimony. Really a lot of information to unpack there. I'm curious if you have, or if there's any data collected between developing an eating disorder and the consumption or use of social media.
Mm-hmm. There definitely is, and I think many of my colleagues will agree as well. It's very challenging because eating disorders are multifactorial. So to be able to pull out all the confounding issues surrounded it gets very challenging. I am going to be preparing a brief to be submitted, and I will specifically look for something like that and add that to the brief. As I said, it's very challenging because of all the confounding factors. We do know that depression and anxiety have increased exponentially since the introduction of the smartphone. And anxiety is, eating disorders are an anxiety-based illness. So there is a correlation there for sure. Thank you.
Thank you, Dr. Elliott. Yeah, it's very challenging, right, when you have concurrent situations going on. But I think we know as parents and as a mom, like, we can see what the consumption of social media and media in general does to our children when we look at anxiety and sort of burdening our kids with adult problems, and then how that impacts their developing brain. So I think the data is going to be very powerful as we move forward, because I think this generation is in a completely different world than we were and any generation has ever been. Mr. or Dr. Van Lieshout, am I saying your name correctly? Dr. Van Lieshout?
Yeah, that's great.
Okay. Thank you for your presentation. I was really struck by one thing you said about you're focused on prevention. Do you have a key on how we prevent postpartum, on how we prevent illnesses that develop into full-blown disorders?
Prevention is thank you very much. Prevention is an integral part of the package of improving the perinatal mental health of pregnant persons, birthing parents, mothers, and women. The United States Preventive Services Task Force 3 years ago, just before the pandemic, recommended that all individuals who are at increased risk for developing postpartum depression be provided with access to effective treatments. These treatments are not widely available generally, and they are, in their current packaging, is a bit tricky to use because a lot of pregnant people are still working outside of the home, and existing treatment packages are 12 to 18 weeks long and require weekly attendance. And so while prevention in higher risk groups is likely to be helpful to prevent postpartum depression and anxiety and other common perinatal mental health problems, there's still lots of room for innovation. And a number of groups across the country are engaging in this, myself included. We know who is at higher risk. We can identify them. We can support them. And I think part of any kind of national perinatal mental health strategy should involve a focus on prevention for a variety of reasons, to prevent illness, but also to substantially reduce costs as well financially.
I think you made some really great arguments around the cost savings when we invest. I think that's a really, really powerful stat. If I may turn it over to Elisa, I think it's Elisa Simon. Elisa, one of the things a lot of Canadians struggle with when they're looking at charities is making sure when they donate to a charity that the money is going directly to the charity. You know, there's a lot of administrative costs, or maybe there's bureaucracy. Do you feel like right now the funding model is set up to best go directly to the resources you need to help kids?
Yeah, that's a great question. I mean, I think the reality is all of us within the charitable sector really appreciate when there is funding that is undesignated to be able to allow us to use it in the ways that we most need. And in order to be successful and really build scalable solutions, you have to have a funding model that takes in, government support, corporate support, and donations. And by doing that, you're able to hopefully bring together a model that allows you to pay for those things that maybe are a little bit less exciting for, you have to pay for payroll, you have to pay for IT, and those administrative costs are real. But what many donors want to pay for is the direct things that they can see, either a product being developed or something that's directly going to young people. And so I think that the reality is that we have to be supporting charities to understand how to build a robust way to support themselves, looking at all of those different ways, government, corporate, and philanthropic. And not all charities have the ability to do that based on what their fundraising staff is, or even if they have fundraising staff to be able to do that. I think at Kids Help Phone, part of our ability to scale to meet COVID was in shifting our funding model to accept more government funding. For example, we are incredibly thankful to partner with the federal government in so many initiatives. Without that, we would not have been able to scale to meet the huge demand that came in as a result of COVID.
Perfect. Thank you so much. We're now going to turn the floor over to Anita Vandenbelt. Anita, 6 minutes.
Much, and thank you to all of you for your testimony. I have a question for each of you, so in 6 minutes, I'll try to be quick. My first question is for Dr. Elliott. You've done a lot of work in burnout among practitioners, among nurses. The federal government has allocated $50 million for PTSD and trauma for frontline and essential workers impacted by COVID. I just did an announcement in my writing about long-term care workers, but I'm just wondering if you could give us some advice about what is the best way to target and deliver that kind of funding.
Well, first of all, I think the feedback and the studies show that burnout comes from feeling a lack of influence or a lack of control in a scenario. And I think the context in which we were living over the last 2.5 years, we were all very uncertain. And then within jobs, often people, if they had more ability to have more control, then we would see a reduction in burnout. And so you want to look at programs that are not coming in and just talking about wellness. They're actually looking at the root, the values that people have, and are able to work in that way, because well-being has many factors: financial, relationships, emotional, physical. And so investing in programs that look at all those factors and not just a yoga class or something that people need to do around resilience. There's much more than that.
My next question is to Kids Help Phone for Ms. Simon, about what you said about equity deserving. By the way, I love that term, equity deserving. Equity deserving groups, and particularly I wanted to ask you about newcomer children. I know that there was funding set aside by the federal government through immigration for, I think, 100 languages to be accessible through Kids Help Phone, particularly when we're seeing Afghan refugees, Ukrainian refugees who've had trauma. How is that going? Is there, and what is the impact of that?
So thanks so much for the question. Yeah, up until a year ago, Kids Help Phone offered all of our services in English and French. Because of partnership with the federal government, we were able to add Mandarin and Arabic. And then with the recent war in Ukraine, we added Ukrainian Russian. But we also wanted to recognize that we have many immigrants and newcomers and refugees coming from Afghanistan. So we also offered Pashto and Dari. And we are getting ready right now to trial 2 Indigenous languages. And so we are moving quite quickly to be able to provide more and more services to young people that speak other languages. And we are on track for next year to be able to provide all of our services in over 100 languages. Our evaluations are finding that in order to do this work, you have to first begin with deep relationships within communities. It is important that we are talking to the settlement and refugee organizations, that we're talking to any place where these refugees and newcomers are spending their time, because the first thing is to build that relationship and trust so that they know to even come to us. And then once they come to us, it's doing the evaluations that we've been doing ongoing about, are we having good impact? Are we seeing reductions in distress? Are we seeing satisfaction levels? And thus far, our numbers have been small, but the output and the evaluations have been quite strong in demonstrating that when they do reach out, they're getting services in ways that they've never been able to access before.
My next question is for Ms. Andrich, and I'm just picking up on something that you said about the fact that sometimes young girls are waiting years before they can get help. And we've been hearing, it seems like a trend in some of the hearings we've had, where really the entry point, rather than prevention, the entry point is the ER. But even if they get to the ER, then what happens is that they may see a psychiatrist, they may get medicated, and then there's no follow-up. If they don't have a family doctor, they don't even know what to do if they're on medication to even get it renewed or monitored. And so the fact that they're even asking for help, and I think we heard this just previously, asking for help isn't enough. What happens if you ask for help and the help isn't there, or it takes years to get? So I want to direct that to Ms. Andrich, although I imagine the rest of you might have something to say about that as well. Go ahead, Ms. Andrich.
Thanks so much for that question. Yeah, I think one of the things that many survivors struggle with is the stigma coming forward about having experienced sexualized violence. Our program attends hospital, but of course we have to be asked to come. And there is a fairly good follow through between folks that we've seen at hospital and folks who use our crisis lines. And there is a little bit of a disconnect, I think, between those numbers and the demographics who come to ongoing counseling, which I think speaks to sort of what Elisa was talking about in terms of engagement with community and knowing that the services are there in order to be able to even think about reaching out to them. And I think it goes back to money for engagement, like even what Dr. Van Lieshout was talking about in terms of preventative care, which is also about education, public education, and building relationships with communities, and having the funding to run programs like that, and the ability to, from our own knowledge of what is needed on the ground floor, on the sort of boots in the field level, to be able to direct money to where those things are going to make the most impact.
Thank you so much. We're now going to turn the questioning over for 6 minutes to Adrienne LaRoche. Adrienne, you have 6.
Merci, Madame la Présidente.
Thank you, Madam Chair. Thank you to the witnesses. You've experienced some sad things, but you also have solutions, and thank you for your contribution to our study at the Standing Committee on the Status of Women. I said it at the beginning of the week, and I'll say it again. We have the awareness campaign on mental health that's ongoing at the same time as the Mental Health Awareness Week, and it's focused on how everyone has their own story. And this year, we see it as a response to the pandemic that impacted everyone. The campaign targeted people of all ages, showing that it is possible to find balance and being a part of the solution in helping someone going through a mental health crisis. So it's essential. And my first question is for, well, perhaps you can all answer, but for Kids Help Phone with Miss Simon, you are a frontline service when people are suffering from mental health issues, and on your website, there's a lot of data, and it's quite interesting. When you talk about your services, you've said there is an increase of your services since the beginning of the pandemic. Can you tell us a little more? I know you said you talked about it during your opening remarks, but what have you noticed as a change in behavior in the young women and girls who have called you in the past 3 years?
Thank you for the question. Yes, we have seen really significant increases in the volume of young people coming to us. Also the ways that they are coming. And so we continue to see very high volumes on our phone line, but we are the only 24/7 texting service in Canada. And so we have also continued to see very, very high volumes in young people texting us. Just as before the pandemic, our busiest times are when everything else is closed. And so into the overnight hours, we are very busy with young people that are reaching out. Often they are reaching out with more serious and significant issues, particularly suicide. But if you imagine the young girl who everyone in the family is asleep and they can't sleep. And so that is the moment that they pick up whatever device they have and they reach out to us. Certainly at the beginning of the pandemic, we saw large increases in young people reaching out about abuse and neglect. Again, everything was closed. The places that often are reporting abuse and neglect, like schools, were not able to do that. And so young people were coming directly to Kids Help Phone. Over the course of the pandemic, body issues, as was brought up earlier, and eating disorders came up in really, really high numbers, as did isolation, anxiety. And young people were increasingly talking to us about the challenges of missing out on graduation, on sports, on all of those things that kind of they were used to or they had been looking forward to. As we have continued through COVID, but things feel like they maybe are getting back to a little bit more normal. Young people are often back into schools right now, face to face. We continue to see high levels of anxiety as young people are trying to figure out what is the new normal. Can you go to school with your mask or not? Are you able to hang out with your friends? When do you stay home? And so, like many of us, young people are still navigating this new world. It's not back to normal. It is a new normal, and we don't know exactly what that is yet. And as we as adults are anxious about that, certainly the young girls and young women in our lives are as well. And so we continue to see a new normal in terms of volume, but in terms of the issues, there are some new things, again, around like missing out and anxiety, but a lot of the challenges are the same that we saw pre-pandemic in terms of suicide, depression, anxiety, and relationship issues.
C'est intéressant, en fait.
It's very interesting, Ms. Simon. You mentioned your texting services and how it can help to stay in contact, but ironically, young people are connected to their devices 24/7. You mentioned the body issues. I think that, yes, that device can help you, but it can be hurtful as well because this young girl can be on social media comparing herself to others, and online hate has increased as well. How can these spaces have an impact on the mental health of young girls, and what measures could we implement at the Government of Canada to protect these young people with less online hate?
Yeah, you bring up such an important point, and it's something we've talked about for years as it relates to cyberbullying. One of the things that often as a parent or a caregiver, your first response when a young person in your life is being bullied, but cyberbullied, is to take away their device or to say, you can no longer go on social media. And yet social media is a double-edged sword. On the one hand, it provides incredible connection for young people. It allows them to feel less alone. You know, we think about the trans youth who is living in rural Canada, who finally, through something like our peer support service, is able to connect with other trans youth. It allows young people to reach out to services like ours. On the other hand, there is a tremendous amount of data about the danger and difficulty of social media, particularly for young girls. So I think that...
Ms. Simon, I know you're going to give some really amazing information, but we do now need to go around. So I do need to go to my next questioner, but I'm hoping that we can get all of that information as well. So I'm now going to pass it over, and online we have Nikki Ashton. Nikki, you have 6 minutes.
Thank you, and thank you to our witnesses today. One of the themes that this committee has been hearing over the past few meetings has been the impact of sexual violence and gender-based violence and the lasting impact and trauma it has on women and girls who are survivors of this violence. One of the previous witnesses at this committee has said that we will not be able to improve the mental health of young women and girls if we don't deal with sexual violence. I know that Ms. Andrich from Clinic touched on this, and I'm wondering if perhaps first Ms. Andrich and then Ms. Simon could talk about the lasting impact of sexual violence and what their thoughts are on the need to act to end sexual violence in our country.
Thank you so much for that question. Yeah, I think one of the things that sometimes is not well understood is the systemic nature of gendered and sexualized violence, which is that it is not simply interpersonal acts of physical violence, but also kind of the water we swim in every day, the way in which women and girls are depicted in the media, the way that we speak about gender roles. The kind of bullying that happens is often gender-based as well. And so I think that when it comes to fighting the impact of those things, it is more about a systemic approach. Part of what we do at clinic is we offer public educational trainings to school districts, to schools. We have visited classes at medical schools and at massage therapy schools, things like that. And I think that those kinds of programs could also be very helpfully extended into schools, elementary and middle school and high schools as well. I know there's lots of programs where people come in and talk about consent and all those sorts of things. That should really be emphasized when it comes to fighting that systemic impact of sexualized violence.
Thank you for that. And I'm wondering, Ms. Simon, if you have anything to add on your end.
Yes, so about 5% of our contacts for girls 5 to about 16 are specifically about sexual violence. And I think that one of the big things that was just being spoken about around that education, particularly for younger girls, to even have the name that this was sexual violence, that this was wrong, is quite difficult, particularly when we talk about what we were discussing earlier around social media, where we are often inundated as young women with images. And so it's very hard to understand where violence begins and ends and where the sexualization of young girls begins and ends. I think that we need to continue to look at investing around taking off sexual online images of girls. Certainly Europe and some other countries have really invested in that. We need to ensure that girls and young women who are being victimized online have a way to stop that victimization. And so education so that girls understand what their boundaries are, the ability to say no, understanding that help seeking is critical. So you don't just keep that in, you actually reach out and talk to somebody. And we know that talking to anybody, any safe and caring adult is going to help that young person, whether it's Kids Help Phone, whether it's a parent, it's a friend's parent. But so talking about help seeking and then making sure that we have the right laws on the books to allow girls to adequately address this, whether it is taking down an image, whether it is moving forward with removing somebody's license or bringing a court case, whatever that is, we need to make sure that the legal system stands behind girls who are experiencing sexual violence.
Thank you. Of course, we know that poverty has a detrimental impact on physical and mental health. Ms. Andrich, you talked about working with communities that are on the margins, in particular Indigenous communities, many of whom struggle in poverty here in our province. And one of the things that we've heard about from other witnesses is the importance to take poverty seriously when we're talking about the mental health of children. My colleague, Leah Gazan, who's the usual member on this committee, has put forward legislation around a guaranteed livable basic income and the need to take concrete action to eliminate poverty in our country. I'm wondering, Ms. Andrich, if you think we should be looking at these kinds of measures as a way of also supporting the mental health of young women and young people in our country.
Absolutely, I think so. Like I said earlier, money is how we talk about what's important to us as a society, and money is often the key out of situations in which women and girls find themselves in danger. If everybody had the option of moving out away from people who are dangerous to them, if everybody had the option of not working at a job that was dangerous to them, if everybody had the option of that kind of freedom and the ability to support themselves, I think we'd see a lot of people in a lot better situations. Absolutely.
You have about 25 seconds left.
Okay. Well, don't think I have time for an answer, but just wanted to share my appreciation for all the witnesses and look forward to some more time for questioning. Thank you.
Fantastic. Thank you so much. We're now going to begin our second round, and I'm going to pass it over to Shelby Cramp. Shelby, you have 5 minutes.
Thank you, Madam Chair, and thank you to the witnesses. Just to start with disclosure, I'm a mom of 2 teenager girls, so this hits very much home with me. Our teenage girls are overwhelmed. parents are overwhelmed. There's teachers that are overwhelmed. There's a lot of people in a dark spot right now. Raising teenagers in 2022 is entirely different, a different experience than our parents had raising me, for example, in the 80s and 90s. Social media didn't exist. Talking about mental illness didn't happen. COVID hadn't happened. Eating disorders weren't trendy. Bullying has always happened, but it's been taken to a whole new level. It's out of control. In some cases, teenagers are now even contributing to families' finances because the cost of everything is outrageous. The pressure is extremely real. It's almost like it's the perfect storm. My first question I'd like to pose towards Miss Elliott, Dr. Elliott. I'd like to talk about diving into the punitive damages that our young girls and youth in general, as a result of COVID, they're missing out on graduations. They're missing out on sports. They're talking about isolation. So where do you see that we can find additional accountability, and what could we do different, and what could the government do different next time if there was another pandemic?
Thank you very much for that question. I have to take a breath because I have a lot of professional thoughts about this, but I also have a lot of personal thoughts about this. Children were at the lowest, absolute lowest risk of impact from the disease. And yet they were the ones that suffered the most. We wrote a letter back in February of 2021, evidence-based, to say that children should be returning to sports, that they were safe to do so. And we were very much supportive of kids being in school and doing their sports. And still, I saw in many jurisdictions, kids were limited. And this can never happen again. These restrictions and mitigations, we see now, and parents will tell us, youth will tell us, the evidence is telling us this was related to isolation, lack of control, and inability to do their developmental milestones. And so with that, I would say this can never happen in this way again. We can't undo what's happened, but going forward, I hope we use the evidence from families, from youth, and from the evidence in the literature, never to do these lockdowns again.
Amazing. Thank you for that. Continuously, we heard we need to increase resources. We need more support. We need to address the people that are help seeking. We need more in-school support. We need to increase spending. We continuously heard this from our witnesses. My last question is posed towards Ms. Andrich. Which barriers, if any, might young women and girls in Canada from accessing specialized and specific mental health supports and services? Because I know we have the telephone health line, but with regards to internet, how much more can we, or what can the government do?
Thank you for asking that. I think this is related actually to a lot of barriers that people up north face, which is that internet is not a public utility like water or electricity, and we are in an age of information. I think that being able to access the internet is, in my opinion, a human right, or should be, and I think it's one of the things that would help people access these services. There's a question of simply geography, I guess, when it comes to being able to talk with a counselor or talk with advocates or other things of that sort. So I think that's definitely one of the things. And just making sure that...
Oh, sorry. Thank you for that. I'd like to acknowledge that because in Hastings, Lennox, and Addington, the rural internet, and I'm sure with many of my colleagues around the room, rural internet is a concern. So thank you for addressing that.
Fantastic. Thank you so much, Shelby. And Jenna, believe it or not, you're going to get your full 5 minutes today. So Jenna, I'll pass the floor over to you for 5.
Amazing. Thank you, Chair. It's my lucky day.
Thank you to all of the witnesses, first of all, for the incredible work that you all do that's so important, but also for sharing your time and expertise with us today. I'll caveat, I'm also a mother of 3 teenage girls, so live and breathe a lot of these struggles as well. And echoing, one of my colleagues was just saying how difficult COVID has been for parents and for children and young girls in particular. And the provincial decisions when schools were closed were difficult decisions that we all lived through. And now one of the witnesses referred to the COVID generation, which I hadn't heard before, but is so accurate. I think I'll direct my first question to Dr. Van Lieshout. You had addressed a few recommendations, and one of them was around Canadian-specific stepped care pathways. And I would appreciate if you could walk us through what you believe that should look like.
Thank you very much. Step care pathways are, of course, the systems by which we deliver and monitor psychiatric treatments so that the most effective and least resource-intensive treatments are applied at the right time. In Canada, we have remarkable strength in perinatal mental health research and leadership and clinical work. There aren't many of us, but those of us that are here, well, my colleagues are great. I'm just okay. But when we're talking about a stepped care model, I think we'd be talking about starting with some quality standards around preconception information and prevention, some quality standards around detection, assessment, and intake, and then treatment. We have, and all of this would be, of course, measurement based. We have lots of wonderful measures in the perinatal mental health space, the Edinburgh postnatal depression scale, and so forth. And so what we'd be talking about doing is sort of trying to identify those individuals who require treatment, and then identifying some low intensity treatments that could be used by most. There's a model within the Ontario Structured Psychotherapy Program that could be used whereby classes and self-directed sort of psychotherapies, CBT-based, usually would be a low-intensity intervention. Then we would monitor responses to those interventions and then determine if people needed more, if they had a poor treatment response, if the treatment wasn't helpful, wasn't good for them, they didn't agree with it. Then we could move up to higher intensity treatments, individual or group structured evidence-based psychotherapies, cognitive behavioral therapy, interpersonal psychotherapies, and things like that, and then medications and so forth.
And you had also mentioned a national care standards. Is that a separate recommendation? And if so, what does that mean? What does that look like?
Thank you. Sorry, I jumped in. So I think I would see the national quality standards as setting the stage for the stepped care models. Quality standards around, across the care spectrum from detection through treatment could set standards for access and wait times and things like that. Once we have those quality standards in place, they could be used to identify human resource needs, and they could be used to guide the coordination of different organizations that are already helping. I sounded arrogant and obnoxious as a doctor there for a second when I said we have lots of expertise. We have fantastic expertise and supports in community organizations around the country. And one of the struggles we have is the coordination of them. There are so many people doing so much good work, peer organizations, community organizations. And what I think quality standards would do is set the stage for us to identify what we need, who we could coordinate. And those things would feed into those step care models and inform them so that we could decide which low intensity treatments are the best that we can do in Canada at present time, and help us decide what determines whether people move up or down to lower or higher intensity treatments.
Incredible. Thank you so much. I'm realizing I don't actually have the time. I wanted to go to Alicia Simon and just dig in a bit to one of your recommendations around in-school supports. I know the chair's not going to give me the extra time, unfortunately, but maybe one of my colleagues will pick it up. Thank you.
You know, Jenna, you never know with me, because I'm thinking I have cut you off for the last 3 months on your questions. But anyway, thank you so much. And we will pass it now on to Andrea and LaRoche. Just a reminder, 2.5 minutes for this round.
Merci beaucoup.
Thank you very much, Madam Chair. I will start with something that I noticed during opening remarks. Ms. Andrich, you talked about the importance of the 94 calls to action in the Truth and Reconciliation Commission recommendations, and there's a link between mental health and violence that many women are victims of, especially when we talk about sexualized violence. You talked about recommendations 21 and 24, and there's recommendation 41. Can you tell us more about how these calls to action could help women and the links to be made with their mental health?
Thank you so much for that question. 21 through 24 are calls to action around our medical system and training around that. 41 is the one that directly addresses missing and murdered Indigenous women and the investigations around that.
Apologies.
Because
excuse me.
Barrier...
Hello. Sorry. There is no interpretation. So if you could just hold for 1 moment, I'm going to reset the time so that Adrian will be able to hear the answer. So do we have interpretation now? Can you hear us, Adrian? We're good? Okay. So if you want to begin that answer again, I will give you back that time. Okay. Go for it.
Thank you so much. Thank you so much for that question. The calls to action 21 through 24 refer to training in the medical system and making sure that there are Indigenous folks represented as medical practitioners. 41 speaks to missing and murdered Indigenous women, the investigation into that and prevention of that in our society. They're specifically important, I think, because part of the barriers of accessing help are the systemic injustices that Indigenous people face in our communities. And having people who are aware of Indigenous traditions, who have been educated as to the harm of colonization, being those front facing people, the people they're going to first experience when they seek help, I think will make a huge difference as to retention of people accessing services and the efficacy of those services as well, if people believe that they are understood and seen.
So I hear the importance of this report and how there's a direct link with mental health in Indigenous communities. And I would like to make a parallel. You talked about the LGBT plus community and how they are victims of a lot of biases today.
Won't have time for that, but we'll be, when we come back to Adriana, I'm sure we will have time. I'm now going to pass it over to Nikki. Nikki, you have 2.5 minutes.
Well, first, I'd like to ask Ms. Andrich to expand on a point that she raised earlier about the lack of resources that Clinic does. Obviously, anyone that I think lives in Manitoba that works anywhere close to the field of trauma, mental health supports is aware of the important work that Clinic does for all of us. And I want to thank you for that. But I'm wondering if you could tell us also clearly the kinds of resources that you would need to meet the need that you're dealing with.
Probably payroll, as Elisa talked about earlier. Our wait lists are hugely long, and we just don't have enough counselors to take everybody on in a timely manner. Unfortunately, the pandemic has only made this worse. I know that in my program, the Sexual Assault Crisis Program, our wait list almost doubled in terms of wait time between 2020 and present day. So yeah, payroll, more people. We're all burning out.
Yeah, no, for sure. And I appreciate you being very very clear on that. And again, just really want to underscore the life-saving work that you do here in Manitoba. Thank you. Quickly, my next question is to Dr. Van Leishout around perinatal care. Really appreciate the critical points you've raised. Here in northern Manitoba, we have an added issue where a number of women have to leave their home community to give birth, ripped away from their support network. In some cases, it's quite recent. I'm thinking of Flin Flon, a major hub in our north that had its entire obstetrics ward shut down, and hearing harrowing stories of what moms from there are dealing with before they give birth, and then certainly after as well. Also thinking of all of the Indigenous women leaving their communities, forced to leave their communities to give birth. I'm wondering if that piece isn't something that we should be addressing when we're talking about perinatal care.
One thing that the pandemic showed us is the importance of supports, family supports, community supports, networks of support people. And so when people are taken away to give birth to their children, it disrupts that. It disrupts the birth process. It disrupts the experience. It increases the likelihood that the births are traumatic or are experienced as traumatic by people. So absolutely an issue that is prominent among the clinical work that we do, and as something that hopefully we'll take into consideration. We're looking at quality standards around perinatal mental health if we get that far.
Awesome. Thank you so much. We'll be getting back to, I'm sure, Nikki. I'm now going to pass it over to Dominique Vien. Dominique, 6 minutes.
Merci beaucoup, Madame la Présidente.
Thank you very much, Madam Chair. Thank you to all the witnesses for being with us this afternoon. We are learning a lot through your comments. I will start with you, Mr. Leishout. I hope I'm pronouncing your last name correctly. Doctor, you mentioned that we need to work to make Canada the best country for our women and girls. I believe we all share that sentiment. And you stated that this well-being starts long before the crib. I have a question on postpartum. What are the consequences, the negative impacts for children being born when their mother has postpartum depression? What have you observed? How long do the effects last in a child?
Merci. Over the past few decades, considerable evidence has accumulated that suggests that the risks associated with being born to an individual who struggles with postpartum depression are myriad. Children that are born into this setting and are about 3 times as likely to experience a grade failure and significant school problems, 4 to 5 times as likely to develop clinically significant emotional and behavioral problems, and about 4 times as likely to develop depression in their lifetimes. These problems can begin as early as toddlerhood, and the research that has followed individuals the longest suggests that this can persist well into adulthood. Postpartum depression keeps individuals from becoming the parents that they want to be. It disrupts the attachment bond. It makes it difficult for parents to respond in the ways that they want to the cues of their children, and has a lifelong effect. The number I quoted earlier is from the United Kingdom. Each case of postpartum depression is associated with $125,000 in costs over the lifespan, 70% of which is due to these difficulties in offspring.
Is it easier, or can it be? Is it easier to identify now than it was years ago? I was a superwoman when I gave birth to my son, and I'm older than a lot of the others in the room here, but that's my second question. Is it more easy to identify now? Because we want to help women in that situation. Is it easier now to identify these women?
I smiled when you asked your question because we used to call the shower in our house Clark Kent's phone booth. When our daughter was born, my wife would go up there, take a shower, and come back out superwoman. So, postpartum depression. We've had the tools to detect postpartum depression for some time. We know what the questions are to ask by family doctors and other primary care providers. We have easy questionnaires that can be asked. I think it may be lots of people go undetected, but it's a little easier to detect because of the good work that people have done around awareness. More people are aware. Reducing stigma has helped people come to ask for help. And so, I think we've improved outcomes for mothers and families as a result of that. But there's still a general lack of awareness, and we can still improve that and improve these pathways to increase the likelihood that these individuals will be detected, and so that we can treat them.
And the mothers, sisters can also help. Do I have enough time for another question, Madam Chair? Thank you, Doctor. Now, Dr. Elliott, you talked about eating disorders, and I find it concerning. I believe that we can associate it to self-harm as well, as that often comes with eating disorders. I've noticed that clothing companies use a more diverse set of models. It seems more positive to have more body diversity and physical diversity of models. Is that a good thing? Are we on the right track? Because it could be negative for women to see what the ideal beauty is for women and girls.
Thank you. That is a lot of ideas at once. And I would say that eating disorders have increased exponentially. There's so many factors. I will say that back in 2014, when I testified in a status of women around eating disorders, at that time, Spain had just announced that models could not be more than a BMI of 18.5. And that was a law. That is a law. And so when we look at that and we look at the models that are out there, and I'm not saying there's a direct correlation with eating disorders, but if that's the image that young women see, then that is, can contribute to eating disorders. But obviously there's many other factors as well. But thank you for the question.
Thanks very much. And I know her time is up, but I just wanted to clarify. You said it's the law in Spain that the body mass index must be? It's the law?
Yes, it's the law. It's a law.
Okay, yes. Thank you. Okay, now we'll turn over to Mark Saray, who's looking like I do right now. So, Mark, you have 6 minutes.
Thank you, Madam Chair, and thank you for the clarification. Un gros merci à tous les témoins.
Thank you to all the witnesses. My questions have to do with national standards. We heard that health is of provincial jurisdiction, but the federal government does have a role to play. So we need to find a way to work together with the provinces to develop bilateral agreements, and they're currently under negotiation. We have a plan for 5 years. The Royal Healthcare Group, a few weeks ago, and you made reference to this, stated that the system is broken, that it is very difficult to navigate for parents and individuals. And I will ask my question to the 4 witnesses, but when we talk to community services and mental health services and for addiction services, when we're talking about young people from 10 to 25 years old with early intervention, Dr. Leichout, you also mentioned coordination or the lack thereof. For example, I was in Sudbury with Minister Bennett at a round table, and the groups mentioned, and they exaggerated, but they said that there are 6,000 organizations and that there is very little coordination?
Start with Dr. Ryan Van Lyshout and then Dr. Elliott. What can you inform this committee on best practices, getting evidence-based to kind of finalize these bilateral agreements so that the money could flow with the provinces and the federal government? And maybe a minute each.
Thank you. So I it is an interesting conundrum to negotiate these agreements between the provincial and federal levels. But I do believe that creating quality standards, the federal government creating quality standards, and discussing with the provincial governments their needs and what they can help with will be helpful. There are many community organizations doing great work. We once surveyed them because we created an app to try to help people with postpartum depression, and there were so many doing such great work but so diverse. And so I think quality standards will help us to then say this is what we're going to do, and we can inform the organizations and the provinces, and then people can get together under an umbrella together to do the fantastic work that we know that they do in isolation, and we can get so much more efficiency out of it and probably save a great deal of money. Dr. Elliott.
Dr. Elliott, and then Alison Simon, please.
Thank you very much. So I think we have to look at where the most expensive care is, and the most expensive care is in hospitals. And so when we can work with community, make guidelines that includes community and the amazing work that they do, and we can move things into the community and partner with community agencies, such as community beds or beds where young people who do not need to be in a clinical setting, but maybe still need some high-level care. Those are the places I think we need to start, and we need to do it, have a national standard for that, and so that each program in each province isn't developing, because it's costly to each person to develop their own standards. So I think this is essential, and I really appreciate the question.
Yeah, and I'll quickly just add, I think two things. One is, while it is a provincial responsibility when we think about healthcare and mental health care, I think there is a critical role for the federal government in order to end inequities based on where you live, and to end duplication and spending. I actually don't know that we need a gigantic amount of more funding. We do need some more funding for mental health. We need more focus on mental health, but we also need to be better at spending the dollars where the evidence shows it works, and moving people from the most expensive services to potentially less costly services that will meet their needs. We have to ensure we have, and that's where we get to the stepped care model that Dr. Van Lyshout spoke about, that we are spending our money in a way that makes sense to that end user. And often that can be a lower cost, lower step on that step care model. And that does require national thinking. Otherwise, we set up many different diverse provincial territorial systems that all have in cost, duplicate, and aren't necessarily using the resources that already exist or the evidence that already exists.
Thank you. Also, Alison Simon, I wanted to ask you about, you mentioned about schools and how can what kind of role the federal government could play and with the provinces to try and get where the youth are for delivering mental health services within schools. We've heard this several times from different witnesses, and I know you get several calls. So what kind of recommendation do you have along those lines?
You have about 30 seconds for this.
Okay, thanks. I think that one of the things would be potentially for the federal government to recommend programming within schools. There are examples in the UK. Their helpline, Childline UK, is in every single classroom in the UK. And right now, a program like Kids Help Phone offers or others, we have to go either jurisdiction by jurisdiction or work with the Ministry of Education in that province or territory to try and get schools. We could have a much more streamlined approach from a recommendation by the federal government that every single young person, for example, is connected with Kids Help Phone 3 times through their education, or every single young person receives education on help seeking, stigma, and mental health. And those kinds of recommendations could go very far down into ministries of education to be able to get these things
Perfect.
into schools.
Thank you so much. We're now going to pass it over for 6 minutes to Adrienne LaRoche. Adrienne, you have the floor.
Merci beaucoup, Madame.
Thank you very much, Madam Chair. My question is also for Dr. Van Leishout. I don't feel like Superwoman right now. I feel like I am facing the challenge of my work life and raising an 8-month-old daughter. So, and I mentioned this before, I'm wondering if I'm able to be a good mother and be a good MP. So I do understand the matter of mental health in young mothers. But Dr. Van Leishout, I would like to come back to the fact that we all agree that there needs to be more investment in mental health. Somebody mentioned that we don't need any massive amounts, but we do need to invest. Community organizations do great frontline work for people with mental health issues, and they need support, they need resources, because the requests for their service have increased exponentially. And in order to help them, they will need more funding so that they can get more staff and offer more service hours. So how is it important to recognize that when we invest in health and that we put more funds into the system through the federal level, and of course it goes through the provinces, so that there are more budgets, how could this help community organizations to respond to the growing needs?
Merci. Congratulations on the birth of your 8-month-old. You seem to be doing an awfully impressive job as a mom and MP, but I'll stop being ingratiating. There are a lot of remarkable people doing remarkable work across sectors at the municipal level, at the provincial level, and at the federal level. Public health in Ontario does a lot around perinatal mental health, these community organizations, hospitals, and so forth. And I think part of the setting of quality standards by the federal government would implement the need for measurement-based care. Ms. Simon alluded to that. It's important that we coordinate and collaborate together, but also measure what we're doing and assess how well we're doing. And organizations that are able to help us produce the best outcomes, that could be one way to determine how things are allocated and so forth. And so a part of quality standards and step care models, of course, is measurement. There are cheap scales that are available that in the perinatal mental health space that can be used to benchmark and create standards and do those sorts of things. So I hope that answers the question you asked.
Et je pense qu'on peut. Oui, j'entends ce que.
Yes, I do hear what you're saying, but the urgency to invest is there. And I know that you mentioned not redoubling efforts and time wasted on those agreements because Quebec and the provinces are asking for a transfer of up to 35% because they recognize that there are programs that can't see the light of day because they don't have the funds. So there needs to be a way to accelerate the process for these transfers. Now moving on to Dr. Elliott, you work with adolescents, and I have some, and they or have some in my family, but what kind of co-anxiety do these teenagers suffer from, and what can the government do to work on environmental issues as well that can help with the anxiety of these young people?
Thank you very much for your question. I think I want to go back to what a few people have discussed is let's bring it back to the family and let's bring it back to the schools and into the community. And one of the things that really is curious to me is why after 2.5 years of such significant increase in mental health concern, and we all spoke about it, that school counselors, psychologists have either been let go or are not deemed necessary. And I've heard several examples of this just in Calgary. And so we need that force in the resources in the schools. And I also think that we need to take it back. I love the prenatal or the early childhood where we teach parents how to regulate their own emotions. They can have the highest IQ, but haven't learned emotional regulation, when the avalanche is coming, you may start doing things that you wouldn't typically do. And I think we need training at different areas, community, places of worship, within schools, where we help parents learn techniques such as mindfulness, emotional regulation. This will help them with many of those things to help adolescents. If you're not in a grounded environment, you cannot ground yourself. And so my approach a lot of the time is working with the parents to help the youth, to coach them to be in a better place and then to deal with the crises. Thank you.
Fantastic. Thank you so much. We're now going to pass it over to Nikki. Nikki, you have 6 minutes.
Thank you. My question first off is back to Dr. Van Lieshout. You've talked about the impact of mental health being passed down from mothers and onto their children. For Indigenous women and girls, we know that there's intergenerational trauma that transfers across generations, trauma that is caused by colonization, the impacts of residential schools, trauma caused by systemic racism, ongoing violence, and genocide. Could you talk a bit about any research that you're aware of or that you've been involved in that is focused on Indigenous women and girls, and how can we best support these communities, whether it's in terms of the national standards you've talked about or other measures when it comes to prenatal and postpartum care?
Thank you. I actually live about 2,000 meters from the Six Nations Reservation here in Caledonia, Ontario. And so we've been fortunate enough to develop links with the Six Nations Birthing Center, a group of Indigenous midwives locally, to try to understand, the unique struggles faced by First Nations people here locally. In addition, I do clinical work and have had the honor of working with First Nations people from Ohsweken at Six Nations and Rama, Nurilia, and so forth. And the stories are striking, as you point out. The intergenerational transmission of many things is quite staggering. When we did a study during the COVID-19 pandemic, working with the Six Nations midwives, and found a number of challenges that have been described by the other members of the panel, access to healthcare and other things. But what we also saw was remarkable strength, remarkable resilience among these individuals, and we think it, of course, was within them as well, but also because they had this amazing birthing center here, and so having First Nation specific supports, people that peers that have recovered. I mean, I think we want to, we have to work together. No health for us without us. We have to work together to understand these unique challenges that are being faced and develop tailored, unique strategies that meet those needs, whether they relate to intergenerational trauma or water security or food security or things like that. So we've been doing that work. We're trying to help train the midwives, and we're doing some training with the midwives coming up soon, and we look forward to continuing that partnership and understanding it better. I have great teachers, and I'm very, very lucky to have that. I hope that helps with the question.
Yeah, I really appreciate the experience you've shared, and I think we can all agree that the work you're doing is very important work, and hopefully work that can be replicated in other centers, right? With and for First Nations across the country and Indigenous communities across the country. I want to move to another topic, and perhaps Ms. Simon, I'm not sure if you might have something to share on this, but obviously we're hearing a lot more about young people who are increasingly anxious about climate change. We've already seen the impacts of climate change on our communities. Personally, I represent communities that have been evacuated, have experienced long-term evacuations as a result of historic wildfires, and just in the last couple of years, where we know that the mental health issues have been further exacerbated. I'm wondering, though, through your work with Kids Helpline, what are you hearing from young people when it comes to what is termed as eco-anxiety or anxiety around climate change?
Yeah, I think that is such an important question, and thank you so much. It's interesting. We are not seeing young people name it eco-anxiety or climate change anxiety right now. What we are seeing, however, is certainly when we experience any kind of disaster related to the climate, whether it is wildfires, flooding, we see an increase in contacts from that area. And I think that we will continue to see young people reaching out about those as we continue to see those disasters occur. And I also think that it is part of our role at Kids Help Phone to start helping young people name that and think through what does it mean and what can they do. I mean, part of a lot of the work that we do is helping young people understand what can they control and what is their role. And when it comes to climate change, young people have to understand they have a voice and they can use it. And so supporting young people to use that voice, whether it is writing letters, whether it is talking about the impact of climate change, that I think is some of the work that we still have yet to come at Kids Help Phone. I want to also connect that to some of the conversations we were talking about just a moment ago with Indigenous people. Certainly, I would say, I mean, at Kids Help Phone, we've done a lot of work with the distinctions-based approach for First Nations, Métis, and Inuit youth. And we are seeing that there are significant concerns from our Indigenous young people around the climate, around what's happening to their communities and the planet that we live on. And being able to have those conversations, we piloted last year and have continued where we trained Indigenous volunteers for our texting line. That's our volunteer service, so that when a young person texts Métis, Inuit, or First Nations in, we can try to connect them with a volunteer of the same background so that they can actually have those conversations about climate change or anything else that's concerning them with somebody who actually understands from that background. And that's been incredibly powerful.
Perfect. Thank you so much for that. We're now going to move over to our next 5 minutes to Michelle Frary. Michelle, you have 5.
Thank you, Madam Chair, and thank you for all of our witnesses and some really great questions that I think are getting some answers in terms of how do we do that bilateral funding, how do we amalgamate mental health into our health care so that when people are asking for help, which I think we've made huge progress in, quite frankly, people are now asking for help, but then when they ask for help, there's nothing there to help them. So there's a huge, huge health equity gap there. Dr. Elliott, I might be your new biggest fan. I'm really enjoying your testimony and a lot of what you have to say. You touched on one area that I'm particularly interested in myself and very passionate about, and that is the education piece of self-regulation and arming our children with the tools, because the toothpaste is out of the tube. We're not going to put social media away. We're not going to reverse backward. This is where we are. And so now we have to give our kids the right tools to manage their feelings, give them the language to manage their feelings, but also not confuse them. I think we also see this too, that they might have something they don't, because they've seen it on, this imposter syndrome as well, which is dangerous. I'm curious what you think would be the return on investment when we look at investing in, and I'm going to name a doctor that I adore, Dr. Stuart Shanker. I don't know if you're familiar with his work, Dr. Elliott, but when we look at self-regulation and teaching children and teachers to recognize the why of their behavior, why do we see it and why now? Dr. Elliott.
Well, I'm really thrilled that you're aware of self-regulation and those topics. As recently, I did a program called Reset to Reconnect, and it was with 6 families, adolescent boys, and we did an initial kind of education, and then they went to it with their families, calling out their families on different things, setting their own plans for their families. And after it was done, the feedback was they recognized that they had better sleep, they were more emotionally regulated, they were more connected to their family, and they had more time to do other things that really social media and screens took away from them. We're also seeing a real significant uptick in somatic symptom disorders, which is when someone experiences a physical presentation because of an underlying psychological event. And for this, we have now seen on social media something called TikTok tics. So when young people are watching a lot of TikTok, they start to get physical symptoms. So to go back to that, if we can teach early parents to regulate and for the young people to be an environment of regulation, whether it's in schools or in places of worship or other places, then everyone's going to have the same language and the same ability to take a breath before you respond. And in so many situations, things are figure outable if you're able to regulate. So I thank you very much for the question.
That's Marie Forleo's saying, figure outable. So I know it well. It's a good one. And I think we're really on the same page. And I think, what we haven't addressed really in this round is parents' inability to self-regulate, which is downloaded to the child, and parents' use of maladaptive coping mechanisms of looking at their screens and just basically tuning out and also scrolling. And I think we need to start to give a name to this, because I actually do think it is comparable, and I'm just going to, alcoholism or some kind of addiction where you are tuning out so that you don't have to deal with the stresses of life, because we have an affordability crisis. We have double working parents who can't afford to put food on the table, who at some point, we have parents now who are writing to me, they make over $100,000. That was a lot of money. And now you can't afford that because the cost of groceries and housing is through the roof. My question, Dr. Elliott, I guess, is where do we find the data, or is there data, because that's ultimately what determines funding, on investing in giving parents the tools they need to self-regulate as well?
So I maybe some are aware of the Pat Palix Foundation in Calgary has done a lot of work on the brain story, and there is a plethora of evidence on early childhood education and prenatal, and really helping individuals understand how the brain works in a very simplistic way so that everyone has the same language. And if you refer to that work, The Brain Story, I think that if you look in Calgary and in Alberta, they have done a lot of work that way. And I'm already seeing that when I work with my youth that are experiencing homelessness and other community. We're all using the same language to describe the young person. They're no longer a difficult youth. They're a youth with challenges.
Awesome. Thank you.
The language is important.
Thank you so much. Absolutely agree. We're now going to pass it over to Emanuela. Emanuela, you have 5 minutes.
Thank you, Madam Chair, and I'd like to thank our witnesses for being here with us today to answer a lot of our questions and for giving us so much great information. My first question, I guess, is that, we heard at several of our meetings, including today, that there is a lack of support and that there just isn't enough help for the amount of help that is needed. Whether that means trained therapists, people who are actually considered psychologists, there isn't enough of them around. And even if people, even if there were enough around, it's quite unaffordable for many Canadians. what do you think our government, specifically the federal government, can do to help make mental health care more accessible to Canadians across the country? And I'm specifically talking about costs, but also getting more people into this field and making sure that we are in the future more prepared to deal with this type of crisis. Anyone can answer.
You haven't directed it to anyone?
Yeah,
So
anyone can answer, whoever would like to.
The first thing I can think of is making mental health care part of our healthcare system. Right now, if you want counseling, you either go through your work, EIP, or you go to a free agency like clinic, or you pay out of pocket. And if you are looking at EIP, those sessions are very limited. Some people have as little as 6, which is not a lot of time to work on any kind of mental health issue. Free agencies like mine, the wait lists are quite long, and for private, it's quite expensive. So I think integrating mental health into our healthcare is definitely a piece of that puzzle.
Does anyone else want to chime in?
So the Royal College of Physicians and Surgeons, quite a few years ago, said that all physicians should be educated in mental health and physical health. It doesn't matter if you're an orthopedic surgeon or a brain surgeon or a pediatrician. And I was on a Royal College subcommittee, and I've yet to see this actually happening. We are seeing more and more physical presentations of psychological issues, and people say, I don't know what to do. You know, other physicians, other people, they're very much physical versus mental health. It needs to be integrated. That education has to start in medical school. It has to start in nursing school. It has to start in all the schools where healthcare is being trained, and they're not separate. There's not a dualistic system. We come into a room with our brains, and so we need to really support that from the education perspective.
This might be a little bit far-fetched, but you raised it, so I'll kind of go along with and take further what you're saying. I've heard that there's a link between sexual assault and cancers, specifically reproductive cancers, and I'm wondering if this is something that you've also read about in your research, if you've seen that, and if what you're saying right now can also lend itself to that kind of work.
Well, I mean, if someone has HPV, which they could have acquired with sexual assault, there is definitely a link to cervical cancer.
So you don't, so you don't think that the trauma somebody experiences in those areas can lead to psychological trauma that leads to physical manifestations in that?
I believe that actually trauma raises the cortisol in one's body, and there's many illnesses that can come from having a trauma or specifically a sexual assault. So I believe there is a connection, but I don't know the literature around this, and that would be something that I would need to look at, the correlation of that. But I definitely think anytime the body is stressed, they're more at risk for illness.
Anyways, thank you very much, and sorry if my questions were a little bit all over the place. A lot of these topics hit very close to home, so it's very hard to actually concretize my thoughts. Okay.
Hey, thank you so much, and that's why we're a committee doing this all together. So let's just continue in this great work that we're doing, and we can ask these tough questions together. I'm now going to pass it over for 2.5 minutes over to Adrian. Adrian.
Merci beaucoup.
Thank you, Madam Chair. Dr. Elliott, I didn't react quickly enough, but earlier you mentioned a law in Spain. Could you elaborate on this, please?
I'd have to go back to look at the year that they put this forward, but I do know of a law in Spain where they said that models need to be a BMI of, I believe it's 18.5 or higher. They cannot be below, or maybe it's 18, but it is a law. And so absolutely no models can be below that. The other thing they have, which is incredible, is sizing is consistent. I don't know if you've ever gone into a store that's been open for 20 years, but the sizing is not consistent. And so in Spain, it's actually a law that a 30 is a 30, a 32 is a 32. There's no 4s that are 8s. And this has a huge impact on body image and for women and young women and girls. And so that's also a law in Spain.
Merci beaucoup.
Thank you very much. At the end of a meeting, I always try to clarify things, but now, Ms. Simon, we talked about digital and how Europe invested in that. Do you have any more concrete examples that we could find inspiration in order to act on that?
So I think part of what we have seen, particularly over COVID, is people all across the world looking to e-mental health and digital health as a solution to their challenges. And certainly when we think about that stepped care model, digital health is really fantastic for a lot of those lower acuity challenges and single session counseling, things like that. I think that the thing that I think is worrisome is we have seen a flooding in the marketplace of for-profit companies, both within Canada, but even more so internationally, coming into our marketplace and offering services, digital services, without a lot of efficacy or evaluative information behind it. Cost, so that we are creating a second tier of services that people can choose to pay for. And when we talk about things like navigation, it is becoming incredibly difficult. Go to the Apple or Google store and put in mental health, and you will see hundreds of apps. And that's just apps. That's not even talking about the other kinds of digital services. So I think standards for digital supports and ensuring that companies that are coming into Canada to provide digital services are able to demonstrate that there is efficacy and evaluation behind the products that they're offering to Canadians.
Thank you so much, Ms. Simon. Sorry, we're now going to move over for 2.5 minutes over to Nikki. Nikki, you've got the floor.
Thank you. My first question is to Dr. Elliott. I know you highlighted the fact that you work in Alberta, and I obviously really appreciate the insights you shared around working with girls and young women around eating disorders and anxiety disorders. And I'm wondering, similar to perhaps other questions that I've raised during this committee, is insight that you can bring in terms of challenges, particularly around anxiety disorders, but perhaps also eating disorders, and working with Indigenous communities. We know that many Indigenous communities face high food insecurity. The cost of healthy and a balanced diet is out of whack compared to the rest of the country, and obviously the resources are even fewer when it comes to mental health support. So I'm wondering what insights you could share in working with perhaps Indigenous young people, Indigenous girls and women, and concrete, I guess, perhaps any concrete recommendations you can make to our committee.
Thank you so much for the question. I've had the honor of working, developing a clinic with Woods Homes, which is a not-for-profit in Alberta, and creating the CATS clinic, which is the Calgary Adolescent Treatment Services. And very sadly and unfortunately, we have 30% Indigenous youth that come. And I say that is because only 3% of Canada is Indigenous. So I'm very saddened because many of them are coming because they're anxious. They have had sexual assault. They've had other things where they need to come to a clinic like ours. And so, but the hopeful thing is that we have specialists in intergenerational trauma. We have people in the clinic that work with these youth and get them the right resources. And so I'm heartened that we have that available through Woods Homes. I'm very saddened that the percentage is still very high.
Thank you for sharing that. And I'm wondering, perhaps, would you recommend that there be greater resources dedicated towards working with obviously overrepresented community in this field?
Definitely marginalized communities, youth that are experiencing homelessness, Indigenous, very diverse youth. There's a lack of services. It isn't that sometimes they're there, but sometimes they're very nervous about asking for help. They do not want to come to big hospitals. They don't want to go to other clinics. And so we need these specialized clinics for them to feel non-judgment and they're accessible.
Fantastic. Thank you so much. We're coming to our last round, but what we're going to do is, and I'm sorry, Jen, I never do this for you somehow. I'm so sorry. We're just going to pass it directly over to Sonia for her 5 minutes so that everybody has had the opportunity to ask to our witnesses today. Special treatment for the Vice Chair. I'm sorry, guys. Anyway, I'm passing it over to you, Sonia. You've got 5.
Thank you, Madam Chair, for being generous to me. But thank you all the witnesses for the very valuable, output. Being a mother of twin daughters, I know. I might just want to ask a question coming back on eating disorder. Eating disorder, you said, Dr. Elliott, is increasing. So what is the main reason of that disorder?
Well, in general, eating disorders are a multifactorial illness. And when I say that, there is genetic underpinnings and serotonin receptors. There's context of environment. There is social media and screen has been alluded to, the impacts of body image. It's an anxiety-based illness. And during COVID, the last 2.5 years, we have seen our wait times go from 1 to 2 weeks for a specialized tertiary care program to 56 weeks in 2001. And now I think they're down to about 40 weeks. And so the basis of this seems to be about control, about loss of control and isolation. And many youth would say that when pandemic hit, they needed to focus on something, they needed to control something, so they controlled their food. And once you become malnourished, the brain becomes malnourished, you go into rigid patterns. And then all of a sudden, you have a youth that is starving and having all the complications of malnutrition. And so, again, it's multifactorial, but COVID and its isolation really had a significant impact on this population.
Do you have any research some youth have a gluten-free or celiac disease because they cannot get food because they're so scared to, if they eat gluten, or that can be a cause too?
Yes, I think what you're speaking to is a diagnosis called ARFID, which is avoidant restrictive food intake disorder. And we can see that coming. Someone does not have a body image issue, but they've had a choking event or they've had severe abdominal pain from maybe celiac or other illnesses. And then they become very fearful of eating and they can become quite malnourished as well. And we need more funding in that area. Specifically, it's quite a crossover between GI specialties, pediatrics, and psychiatry, and there's such a lack of knowledge in the community around it. Thank you for the question.
Thank you. My next question is to Ms. Simon. Ms. Simon, you said 25, the age you said more than 25 years, they are more in grief. Do you think they have anxiety or any other reason to being towards the mental health issues, or just the early age? You also said the suicidal thought starts from the 5 to 13. Is that true?
Yeah, so as I mentioned, we do hear from young people between the ages of 5 and 13 that are thinking about or talking about suicide. And again, the important thing to me about that is that when a young person reaches out, we have this unbelievable moment to help them. And so the fact that they are willing to talk about it, it's scary for us as adults, and it is shocking to hear about young girls that are reaching out about suicide. As a parent to a young girl, I feel that. But I also want to just really drive home the fact that they're talking about suicide is okay, because it allows us to have that moment to talk to them about hope, about resiliency, about inner strength, about being present in your own life, about what coping tools they have. So yes, we are hearing from young kids about suicide. The other question that you asked was about older and 25 plus. Certainly, we see from 25 plus young women talking about anxiety, depression, relationship issues, all of those things. We don't diagnose at Kids Help Phone. We have done evaluations where we've asked young people to take a scale called the Achenbach to get a sense of whether they have diagnosable challenges. And certainly we see large numbers of young people coming to us that do have diagnosable conditions. But we deal more with what the feelings are in that moment, and the feelings that 25 plus bring to us are high levels of anxiety, lots of depression, lots of feelings of their life being out of control. And as I said, what we have noticed is, particularly for those older young adults, them bringing in challenges around grief and around loss. Again, around the pandemic, we think about post-secondary students who haven't been able to go. We think about people who haven't been able to see their family, who are feeling isolated. And that has continued in this new reality. And so I would say young people reach out about every issue, and every issue at every age. But those are some of the differences we see as young people age.
Awesome. I would really like to thank the panelists today. Thank you so much to April, Ryan, Alyssa, and Carla. This has been a phenomenal panel, and thank you for participating. As indicated, if there's additional information that you would like to send in, we are accepting that till November 1st, okay? Just to everybody, we are going to be adjourning our meeting. I would like to say thank you, and to everybody, happy Thanksgiving to you all. Time to go home, put up your feet, and enjoy a turkey or something with your family. I hope everybody enjoys it. Are we ready to adjourn? Sound good? Okay. Today's meeting's adjourned. Thanks.